So now we will talk about colloids. We already discussed colloid is aqueous solution of high molecular weight substance. Now these substances are held in solution by strong covalent bonds which attract waters. So the use of colloid is for volume expansion. So how does colloid do the volume expansion? What is the Starling's hypothesis which tell us about the function of colloid? What are the different types of colloids, the natural and the artificial? And what are the problems associated with colloid infusion? What are the side effects? All we will discuss in this section. So let us start our discussion with simply what is colloid. As I already said, colloid are solution in which the molecules of the colloid are held together by strong polar covalent bonds that attract water. So effect of colloid can be traditionally explained by Starling's hypothesis. The Starling's hypothesis says that transcapillary flow depends upon hydrostatic and oncotic pressure. And what is colloid doing? It is increasing the oncotic pressure. So colloids are the molecules which do not cross the capillary membrane, the capillary endothelium membrane. So they remain in the intravascular space and increase the oncotic pressure. And this increase in oncotic pressure causes the pull of the fluid in intravascular space. This is the mechanism of their volume expansion. But actually, the studies showed that volume effect by infusion of colloid and crystalloid was just marginally different. Then when colloid is molecule which is exerting such a high oncotic pressure, why this differences was seen only marginally? So a new hypothesis came into existence. A new, let's say, revised Starling's principle came into existence, which now truly explains how the colloid acts. What is the main way by which it can cause the plasma volume expansion? So they are held together by strong polar bonds which attract water. First, I will talk about the traditional Starling's method, which was originally describing, and now it has been replaced by the new Starling's hypothesis. So, effect of colloid in plasma volume on plasma volume was previously explained by Starling's model, by classical Starling's model, right? The classical Starling models say that the transcapillary flow depends on your hydrostatic and oncotic pressure, depends on hydrostatic and oncotic pressure. Okay, so in this model, what was seen when we gave colloid, which contains large organic molecule such as colloid, do not cross the vascular endothelium, right? So they exert a oncotic pressure. So exerts oncotic pressure which causes movement of fluid inside the blood vessel, causing movement of fluids inside blood vessel, right? The volume expansion would be proportional, the volume expansion by colloid would be proportional to the molecules or ions of the colloid solute, molecules or ions of solutes, that is of colloids. So this was Starling's principle or Starling's hypothesis, the classical Starling's hypothesis. So the classical Starling hypothesis has one more thing which was said, that only 10% of the interstitial fluid is absorbed by the lymphatic and returned to the main circulation. 90% is again by the pressure difference gets absorbed in the systemic circulation. Now this was also negated, and it was said the total 100% of the interstitial fluid is returned to the circulation through the lymphatic system. So a lot of fallacy was there in the outdated the original Starling's hypothesis, right? So revised Starling principle came into existence, and this revised Starling principle used the concept of subendothelial space and the subendothelial layer of Glycocalyx. So revised Starling's principle, this showed the role of endothelial Glycocalyx, right, on transcapillary flow. Okay, so what is this endothelial Glycocalyx? So we'll talk about this Glycocalyx layer. Now this is just if this is the lumen of the blood vessels, this is the lumen of the blood vessel, this is the endothelial lining. Now this would be the subendothelial Glycocalyx layer. So this is inner dense matrix layer of membrane attached glycoprotein, right? This forms a selective barrier for the protein molecules or plasma molecules. So this is a selective barrier to plasma macromolecule. So when this Glycocalyx layer came into existence, the subglycocalyx space also came into existence. So if you see this lumen of the blood vessel, this is the lumen of the blood vessel, this is the Glycocalyx layer, this is the subglycocalyx space, and this is the vascular endothelial. Now in vascular endothelial there are channels. These channels promotes the movement of the fluid across the blood vessels, right? So this depends upon the hydrostatic pressure. When this hydrostatic pressure, and the fluid moves along this cleft, the opening in the endothelium, but the protein does not move through this opening. It moves through the large pore which is present in the endothelium. Now when the hydrostatic pressure decreases, what happens? The hydrostatic pressure decreases. What happens? The movement of fluid across the cleft decreases. And what happens? It becomes slow or decreases. And the difference in the oncotic pressure of the intravascular space and subendothelial space, that is the subglycocalyx space, also changes. So when this difference in the oncotic pressure changes, this encourages the reabsorption of the plasma protein, right, in subglycocalyx layer, and this causes movement of the fluid across the membrane into the vascular into the, let's say, the lumen of the vascular endothelium. So it goes in the lumen. The movement of the protein is in the same way through the large pores. So because of the change in the oncotic pressure of intravascular space and the subglycocalyx layer, the movement of water takes place from the outer into the vascular lumen, right? Once everything is restored, again the movement will stop. So it is not something like that a total oncotic pressure exerted by the macromolecule colloid in the vascular lumen would produce an oncotic pressure and pull the water inside the vascular lumen. It is not so. It is the difference between the oncotic pressure of the vascular lumen and subglycocalyx layer which is responsible for the movement of fluid across the endothelium into the lumen of the vessels. Okay, so this is your revised Starling's hypothesis, and this also said that 100% of the lymphatic return is happening to the venous system. Whatever interstitial fluid is accumulated, it is 100% returned by the lymphatic system. Okay, so what does this say? The revised Starling's principle, right? About this selective barrier plasma or to plasma macromolecule, the glycocalyx layer. So low oncotic pressure of subglycocalyx space, and not interstitium, and not the interstitium, which is responsible, that is principal determinant of transcapillary blood flow, right? So this subendothelial oncotic pressure is responsible for the transcapillary blood flow. Okay, and apart from that, as I mentioned, the interstitial fluid, the accumulated interstitial fluid returns to circulation entirely 100% by the lymphatic system. Okay, so this is revised Starling's hypothesis. And when this was known, when this came into picture, another thing was discovered, that structure and function of this endothelial glycocalyx layer, they vary from system to system, the different vascular beds in different system, and also differs in different disease condition. So what was the important thing which was noted? The structure and function of endothelial glycocalyx, vary in different vascular beds, and vary also under different physiological and pathological condition, and also vary in different physiological and pathological conditions, right? Now remember that this integrity and the leakiness of glycocalyx varies substantially between the organ system, and it is also increased in systemic sepsis, or it is also affected by the local infection, etc. Right? So it is something which is changing depending upon the physiology and pathology of the patient. What is the clinical implication? Of this finding? Increased capillary permeability and fluid extravasation of sepsis, burn, or polytrauma can be explained, right, by this damage of glycocalyx barrier. So when this glycocalyx barrier gets damaged in sepsis, trauma, and burn, the increased capillary permeability and lot of fluid is extravasated in the interstitial space. Now this hypothesis can even be more established by observing that isolated hypoalbuminemia never produces any peripheral edema, rarely produces peripheral edema. So isolated hypoalbuminemia rarely produces peripheral edema, Okay. So what is the role of colloid? What does colloid do? What is the ability of colloid? The colloid has ability to maintain the integrity of this glycocalyx layer and to restore the integrity in case of any damage. So what does colloid do? Colloid maintains and restore integrity of Glycocalyx. Glycocalyx, right? So when it does so, it maintains the microcirculatory function. It restores the microcirculatory function which is happening around the blood vessel. So colloid restores microcirculatory function, right? So this is how the colloid is functioning, by maintaining the integrity of Glycocalyx and restoring the microcirculatory function. Okay. Now let us, after understanding this, how does the colloid act by this revised Starling's principle, let us discuss about different types of colloid. Now colloid, as we have already discussed, can be divided into two: natural and artificial. Natural colloid is your blood and blood products and albumin. Artificial colloids are our starch, gelatin, gelfusion, our dextrin, all these things we will discuss. So we will discuss the albumin, we will discuss the starch solution, we will discuss the gelatin, we will discuss our other colloids, artificial colloids as well. So starting the discussion with the natural colloid. Natural colloid, in this I will discuss albumin, the most common one which is used. Okay, so albumin is a colloidal solution with a homogeneous molecular weight. In spite of the varying percentage of albumin, 4%, 5% or 20%, the molecular weight of the molecule of the albumin in the solution would be same. It has a homogeneous molecular weight of 69 kilodalton. So natural colloid albumin. Now this is a colloid suspension, is a natural colloid solution with homogeneous molecular weight, right? So what is this homogeneous molecular weight? 69 kilodalton. Okay, and we have three types of albumin: slightly hypooncotic, isooncotic or hyperoncotic. So we have slightly hypooncotic, your isooncotic, and hyperoncotic, right? So hypooncotic is mostly 4% solution of albumin, iso is 5%, and hyper is 20%. And all three are prepared in isotonic salt solution, right? So all are, the solvent for all is your physiological saline, right? That is normal saline. The maximum dose of your albumin is unlimited. It is not, there is no maximum limit. So remember, dose, there is no maximum limit, right? It is unlimited, no maximum limit, no recommended maximum limit. Now isooncotic albumin, what does it do? It results in plasma expansion equal to the volume which we have infused. So if I am using the isooncotic albumin, right? If I am using isooncotic albumin, then it will produce same amount of plasma volume expansion as the volume we have given it. So isooncotic albumin produces expansion of plasma equal to volume infused, right? Hyperoncotic albumin act as a volume expander with large increase in the volume and mostly used after paracentesis, right, in ascites, etc. Okay, so hyperoncotic albumin are volume expanders. They expand the volume in large amount. They are mostly used in ascites when patient after paracentesis, right? What is the risk associated with albumin infusion? So what is the risk? It's a natural colloid. It is human colloid. So it is, let's say, derived from blood. So there is a risk of infection. Though the method by which it is separated minimize this risk. Then the second